Okay, we just started live streaming. And I'll go ahead and start our recording now too.
Oh, Brenda said she's on, but she's not sure if we can hear her.
Who? Sorry.
Brenda Gale.
Let's see.
You don't see her?
She's not in the attendees to be promoted, and the only two panelists is you and I.
I see. Oh, you know what? I think they're all logging on as me. Is that possible? How's that possible? The unique link. Dr. Beeman, they're all logging on as me. That's what it is. What can we do about that? You just like add every video credit and just have them change their names. Hi, everyone. Sorry, just change your name on the, you click the three dots and yeah. I was trying to make it easy on you so you didn't have to go through the whole registration process. Mystery solved in terms of why is there another writer on here? Awesome.
Oh, that was confusing. I just renamed Chris for him.
Okay. Hi.
Okay, I think I got it.
Yeah. Yeah, and Brenda, I think you need to rename your, just click the three dots in the corner. And
Oh, got it.
awesome. Hi, Gina. Dr. Beeman, did I say that right?
Yes.
Okay. Hi, Chris. Just waiting on one more. Yes, about 4 minutes before we get started. So. And I guess if you see another Vita Kreider, Ashley. And Dr. Beeman, when you have your slides, you can just go ahead and start sharing.
Okay.
I'll let you know when to do that.
Sure.
So.
Are we waiting for Judge Stoner?
Mm-hmm.
Dr. Beeman, where did you present? Where did you present in the last 2 months?
Oh, a lot of places.
A lot of places.
Do you know the topic?
I just remember you were fantastic.
Oh,
I'm trying to remember who you were with, but I'm not going to lie to you. I kept thinking, who is that young teenager up there talking so well? And here you are, an accomplished. So,
2 months, and you don't remember the topic?
I'm trying to remember. You were great. I just remember that.
I appreciate that. I speak a lot on opioids. So
was it in relation to you guys? Are you with OSU?
Mm-hmm.
And you guys were doing maybe talking about the need to create more opportunities for students to go into psychology, mental health.
Yeah. Oh, you know what? I bet it was. It was the Oklahoma Academy.
Oh, that's exactly what it was.
Yeah.
Exactly what it
Oklahoma
was.
Academy at the casino.
That's exactly what it was. Yeah. Right on.
Yeah, I had a lot to say in just like a few minutes to say it. So, but I appreciate your kind words.
Absolutely. Hey, Brenda Gale. Hey, Gina Ritchie.
Hey, Chris.
Good to see you guys.
Good to see you.
Hey, Chris.
Gina, I don't even know if I saw you today.
I know. It's moving pretty fast.
But I see you now. That's good.
Just don't put me on the spot, okay?
I will.
Exactly what we're going to do. All right, a few more seconds and we'll get started. Hi, Judge Stoner.
Hey, how's it going?
Good. Can you rename yourself? I can. Awesome. Okay. All right.
Hey, Judge.
Good to see you.
Great to see you.
Hi, Judge.
Hey,
All right, well, let's get started. It is 6 o'clock. So welcome to our March community conversation, Decriminalizing Health Crises, Mental Health and Addiction in Oklahoma. I'm Evita Fox Kreider with Oklahomans for Criminal Justice Reform, and I'll be your moderator for the evening. As usual, we're bringing to the table some of Oklahoma's top experts to share their knowledge with us. And this evening, we have Dr. Jason Beeman, the Chair of Psychiatry and Behavioral Sciences at Oklahoma State University's Center for Health Sciences. He is also the Director of Training and Education at for OSU's Center for Wellness and Recovery. We have Whitney Sapola, an advocacy specialist with the Mental Health Association of Oklahoma. Brenda Gale, who serves as an administrator with the Department of Corrections, Community Sentencing. Gina Ritchie, a reentry case manager with TEAM, as well as an OCJR ambassador. Chris Steele, former Speaker of the House and current executive director of TEAM, as well as senior advisor for OCJR. And last but not least, the Honorable Judge Kenneth Stoner, who serves as district judge for Oklahoma County, presiding over drug and DUI diversion courts. So thank you to each one of our panelists for being here today. We really appreciate you giving your time. And to our viewers watching us on Zoom or Facebook, thank you for tuning in. We love, by the way, reading your comments. So please leave them in the chat and let us know what you're thinking throughout the discussion and how what you're hearing is impacting you. All right, now let's get started. So 13 years ago, Congress designated March as National Criminal Justice Month, calling for public education on the causes of crime, crime prevention, and the criminal justice system itself. So with that in mind, we wanted to focus our discussion this evening on the correlation between incarceration in our state and untreated addiction and mental illness. So paraphrasing Bruce Western out of Columbia University's Justice Lab, for people facing untreated addiction and mental illness, our prisons and jails designed for punishment and detention have become de facto detox units and mental health facilities. Now, this has certainly been the case in Oklahoma. We have a track record of incarcerating people with addiction and mental health issues. We have made some progress, but there is so much more work to be done. So let's talk about what we can do or what we're currently doing to decriminalize people experiencing these types of health crises. I'm going to throw the first question to Whitney, Dr. Beeman, and Judge Stoner. So give us some context. What percentage of individuals in our carceral system are there because of mental health or addiction issues? And what types of crimes are we seeing them charged or convicted with? And then the second part of this question is, why is it even a problem? Whoever wants to jump in first.
Okay, I think I'll dip my toes in. Thank you very much for having me this evening, and thanks everyone for participating. I think that's a really loaded question on what mental illness is leading to incarceration in Oklahoma. First of all, I know in this audience and panelists definitely know that Oklahoma leads the nation in incarceration. So does that mean that we lead the nation in mental illness? Well, maybe. But then why would we lead the nation both in mental illness and both in criminal activity? And is there a common thread? And there is. And whatever bad outcome we're going to talk about tonight, there's always going to be a common thread. And that common thread is adverse childhood experiences. And Oklahoma leads the nation in adverse childhood experiences. Now, when I say that, that's a capital A, a capital C, and a capital E. There's a formal list of traumatic events that a child goes through that leads to bad outcomes as an adult. And I can clearly show you the timeline that young Oklahoma women are traumatized, horribly traumatized in their formative years when their brain is developing. That trauma leads them to seek out impulsive behaviors, high-risk behaviors, be it drugs, alcohol, sex, but also eating and overeating and eating unhealthy foods and lack of exercise and smoking, whatever it is, they do, and it's not limited to women, but it's men, but I'm just focusing on women now. So we traumatize our women as children. Then they manifest the behaviors that trauma survivors do. And because of those behaviors, we lock them up. And basically, we are trying to, in my mind, we're trying to just lock up our trauma. And so I think Oklahoma prisons are a warehouse of generations of trauma. And now I'm not saying that people should be able to commit crimes and not receive consequences for that. I'm saying if we want to stop locking up people in Oklahoma, we have got to stop traumatizing our children, and then we won't have bad outcomes as an adult. And that may seem oversimplification, but the studies have demonstrated that time and time and time again. If we put people in nurturing households when they're growing up, then we'll have a utopian society as adults.
Thank you. That's really good. Judge, go ahead, Whitney.
Oh, I was just going to add in, I think that it is a really tricky question, and I would just name that there's an overlap between factors contributing to the likelihood of someone offending, and also those same factors that put people at increased risk for mental illness. Another really common thing for people experiencing mental illness, they're less likely to have stable employment. So this can lead to committing crimes of poverty, if you will. So property crimes or drug crimes, which are typically nonviolent. They can be, for survival, or they can be to acquire money for continued drug use. I think we see a ton of overlap as well in the homeless population. And so a lot of those crimes associated with homelessness, like loitering, trespassing, those are things we often see people with mental illness with, getting arrested for. Other things as well, like driving under the influence, disturbing the peace, disorderly conduct, things of that nature. And then the last thing I'll add is with a lack of consistent employment, that is very often in the United States tied to our health insurance. And so lack of access to health insurance can make steady treatment a really big barrier and can kind of devolve into these situations where people are finding themselves in the criminal justice system.
Thank you, Whitney.
I'll chime in there. Thank you both for your answers. I know Dr. Beeman went right for the trauma, and yet when you start pulling back the layers, that's what you'll find there. It's a really big question. We do have some pretty good data on at least property crimes. I can tell you that 77% of property crimes are attributed to substance use abuse or addiction, and so. And then you start pulling back what the layers under addiction are, you're going to find adverse childhood experiences, disrupted neurological development, impulsive, high-risk behavior. Even children that grow up in poverty. I've seen some of the studies around if you grow up in an environment where there's not a lot of resources, you don't really learn impulse control very well. Matter of fact, your survival instinct is to act without impulse. You consume now because you don't know what the future is going to be later. And so those are really the underlying. We know I've been around the criminal justice system for 25 years, and first as a prosecutor, then as a defense attorney, and now as a judge. And I can tell you, whether you're dealing with a property crime, even a fair amount of violent crimes, you see a lot of mental health issues. Of course, anxiety, depression are very common. Some people don't even necessarily count those as really mental health, a disease, but they do drive the behavior. A lot of that drives the, self-soothing behaviors as you get wrapped in addiction. And once you get wrapped in addiction, the part of your brain that does impulse control and can understand the future consequence of current behavior doesn't work well. Your executive function. And so it's complicated because as Chris, as Dr. Beeman said, if you are committing a crime, there are victims of the crime, and we have to respond in some way, but we've got to get better at our calibrating our response more appropriately to address the underlying risk. And I think at least the treatment courts were well suited to do that, but outside of that, it's not particularly well refined.
Thank you. So now when someone finds themselves incarcerated because of one of the behaviors that you all just talked about, and maybe they have an addiction or mental illness, and we know there's treatment programs in prison. Why do you think, and Chris, and I'm addressing this to you and Gina, why do you think we need to have programs outside of prison that maybe these programs inside the prison are maybe less effective than ones that are outside of our carceral system? That makes sense. Go ahead,
Sure.
Chris.
I'll jump in. First of all, let me say, and this is no slight on our friends at the Department of Corrections, because I really do think the agency is doing the very best it can. But there's two things that I think are worth noting. First and foremost, there is limited program available inside a prison in Oklahoma. It's not comprehensive and it's not available to everyone. In fact, I had a conversation as recently as yesterday with a woman who's currently incarcerated, and she said, you would not believe the temptation and the amount of drugs that are available on the yard. And that's true of in the jails in anywhere. I mean, that's just the reality of the situation. So I think it's very, very important to note that not everyone has access to programming while they're incarcerated because of a lack of funding and a lack of services that are provided. The second thing I would say is the research that I've read and that I'm familiar with is very clear that if it is an option to provide treatment to an individual who is incarcerated or to an individual who is in the community, it is much more effective to provide that treatment in the community, because they get to apply the skills that they are learning to real life situations, and it's not a false situation that's antisocial. They get to apply the skills that they're learning in treatment as they are paying bills and working a job and managing a household and being a productive citizen and so on and so forth. I think it's crystal clear that we can be much more effective in the long-term outcomes of treatment if the treatment is applied in a real life situation. So I think that we have to understand that. And then just another thing that I wanted to underscore, this notion, and this is already a great conversation. These guys who are participating, you are the best of the best. And I would just say that this notion of adverse childhood experiences in Oklahoma is real, just to underscore that and make sure that our audience understands what we're talking about. I recently reviewed what are the most common adverse childhood experiences that a woman who is incarcerated in Oklahoma have experienced, and the answer would be they grew up with someone in the home who had a problem with alcohol abuse. They grew up with someone in the home who had a problem with drug abuse. They experienced physical or sexual abuse as a child. They had a parent that was in prison. They were raised by individuals outside the home, and they experienced violence in the home. And so the reality is, when we look at that, and then we also consider the generational sort of dynamic that then happens to the kiddos of parents who are incarcerated. And the most common adverse childhood experience that a child experiences who has a parent who is incarcerated would include depression, struggles in school, trouble with their guardians, drug problems themselves, issues of running away, pregnancy, and then severe mental illness and so on and so forth, anxiety and such. And I really think it's important that we at least stop to consider that what we're currently doing in offering a response of punishment to mental illness may not be the best solution. In fact, it appears that it's creating generational cycles of both adverse childhood experiences and incarceration within family units. And I would just offer very clearly that addiction is a disease, it's a health issue, and it ought to be treated as such. So individuals who battle addiction and mental illness should be viewed as patients, not as prisoners. I think it's very, very important that we note that. And I think it's also important that we get serious about addressing these root issues in an effective way. And we really need to use an evidence-based approach. Judge Stoner, I think that you've set the standard in this, but I think it's very, very important that we look at the research and we just don't assume that treatment inside a confined facility is going to be the best situation for an individual who needs help. I think that we should consider better approaches, more effective approaches. And then we also have to understand that it is entirely possible to hold an individual accountable and not rob that person of their dignity, their self-worth, or their freedom. I think that accountability and punishment are actually two completely different things, and we can absolutely pursue accountability without having to punish people into instability.
Thank you, Chris. That's really good. Gina, I know this issue is personal to you. You mind sharing a bit of your story and what your thoughts are about, go ahead.
Yes, being formerly incarcerated, I see firsthand that there's no rehabilitation in prison. For mental health, they put a pill on it and they deem you mental health. You don't have to do anything. You don't have to do, you don't have to function inside the prison. They medicate you. So when you're released, you lose that medication and you're just let out, and they don't have the bridge to bridge you with outpatient, on the outside. So you don't deal with your mental health. So that leads you to self-medicate, back to substance abuse. That leads you to reoffend, because for one thing, when you get out, you got a felony on your back. So it's hard for housing, it's hard for employment, you got everything stacked against you. And so it's easy for you to go back to those unhealthy environments because you don't have, you haven't had the bridge or the resources. They haven't given you the resources once you get out to take care of your mental health or to take care of your substance abuse. You've got 1,200 inmates and you've got a 25 space class. Not everybody's going to get in the class. By the time you're ready to get up on the list, they're moving you to a different facility. You go back to the bottom of the list. So there's no rehabbing incarcerated. So we have programs like Team, Remerge, and Diversion Hub on the outside. But,
I think she froze. Oh, Gina, you froze.
Do you mind if I chime in while she's frozen there?
Go ahead.
I just have an analogy. I want to build on what Chris was saying, what Gina was saying. Mental health treatment is not something, it's not like fixing a broken leg. It's not something you do to somebody. You fix a broken leg, you can hold them down and you fix it and you put it together. Mental health treatment is something you do with somebody. You gotta get their buy-in. And in having it one time in prison or having some classes, just like Chris is, imagine trying to learn how to ride a bicycle in a classroom. You don't learn how to ride a bicycle in a classroom, you learn it in the real world. And so when you have the stress and pressures of the real world, when you're giving treatment on the outside, you really have the opportunity to deal with somebody, the ebb and flows and the ups and downs of life and ride with them. And you're doing it with them instead of to them. And we've got to, that's why treatment inside of prison, I'm glad we have it. We need more of it, but it's really not nearly as effective as on the outside, working with somebody. It's like when you learn how to ride a bike, you got to fall off and get back on, fall off and get back on, fall off and get back on, and get some instructions and keep trying. And that's really what growth looks like. I mean, if you look at recovery, it's really a process of kind of 2 steps forward, 1 back in the real world. It's not, staying sober in prison. Yes, there are drugs there, but it's when you get the challenges of real life, that's really where the rubber hits the road.
Mm-hmm.
Gene, I'm sorry, you got frozen there for a second. Gene.
Yeah.
I just hopped on top when you got frozen. Do you want to finish what you were saying?
Gina.
So I was just saying, yeah, we need the outside, there's no rehab in prison. You've got to get, we've got to have where we can bridge this, make this bridge for those coming out of incarceration to get the help that they need. And they can be productive members of society. Got to invest in people and not look at them as a felon, but as a human being. And give them the resources that they need to rebuild their life. They can do it, but if they feel like that they're just, they're getting hit left and right and there's no help available, then of course they're going to reoffend, of course they're going to relapse, and of course they're going to go, recidivism is a spinning circle, go back in. So
Thank you, Gina. So earlier, Dr. Beeman, he touched on it very well, but on women and the generational effects. And Brenda, I know you've worn several hats within the Department of Corrections. Can you speak to what you witnessed in terms of the effects of women who maybe have children that are incarcerated, and what happens, if they incarcerate for substance abuse or mental illness?
Yeah. So my name is Brenda Gale. I'm a local administrator with community sentencing with the Department of Corrections. And what we do in community sentencing is we're a diversion program. So if someone has mental health, substance abuse, or co-occurring needs, instead of sending them to prison, they send them to us, and we work with them in the community to help them get the treatment that they need. So I normally deal with people before they get to prison. I haven't really dealt with a whole lot of people coming out of prison. When I was a probation and parole officer, I did deal with some people coming out of prison. They were mostly males though. But I can imagine, like Gina was saying, not having that bridge and not having the resources that they need and being away from their children, and the children as well. There's a lot of trauma that needs to be addressed.
Yeah, thank you. Whitney?
Yeah, from the child's perspective, this can be, earth shaking. There's a really great study that was done in 2010 by the Oklahoma Commission on Children and Youth. And they had this interesting statistic, and I'll drop the link in the chat if anybody is interested. But incarcerated women are almost twice as likely as incarcerated males to report that they had a child of their own living with them prior to their arrest. So in terms of for the child, not only have they lost a parent to incarceration, but likely they're being displaced. That could be in the foster care system, that could be with a relative, it could be a number of things, but that is a very, very impactful thing. And then the other thing I will mention is when women are incarcerated, there's no guarantee they will be placed in a facility that's close in proximity to their children. And that can be a huge barrier in terms of having those in-person visits and being able to maintain a relationship while the mother is incarcerated.
Yeah, and then we're talking about, having healthy communities. It's kind of, we're shooting ourselves in the foot by doing that. So we need to come up with a different way. Well, okay, so we're in this situation. How do we even get to this point where we are treating patients like criminals? What's the kind of background on it? And I'm going to address this to Brenda, Whitney, and Just Stoner, whoever would like to chime in.
Yeah. So I think a lot of us know, some people may not know this, but we did have mental facilities in the past, right? They started with the intent to treat people, but then the ratios of people coming in were way out of control. And the staff, they didn't have enough staff to cover that. So when you have those facilities, it became inhumane and they shut them all down. And that didn't take away the mental health problem that we had. We did away with all of these facilities, and instead we just placed them all into prisons. And that's why our numbers shot up so high in prisons, because now it's all of our mental health patients are in there.
Thank you. Judge Whitney, would you like to chime in?
Yeah, I've seen a similar presentation where, in the 1960s and 70s, as they were closing these, we call it insane asylums, they were inhumane. One flew over the cuckoo's nest. They didn't work well. They were inhumane, and as they were, shutting those down, you start see those populations go down, and the prison populations started going up as they go, through the 60s and 70s, and it's been on a similar trajectory. I think it probably explains part of it. I can tell you just from my experience as a law student, as a lawyer, when I came out of law school, I went to work as a prosecutor, and man, it's really pretty simple. This is what the law says. The law says that if you steal a car, and there's not a little an asterisk in there unless you have a mental illness. Just if you steal a car, the range of punishment is it's 1 to 5 or 0 to 5. And it really leaves a lot of discretion to young, untrained prosecutors that had no experience or training in addiction or mental illness. Most of the judges that I used to practice in front of really didn't either. Matter of fact, when just 20 years ago, as a prosecutor, we were kind of in this mindset, you just have bad people doing bad stuff, and I think over the last decade, at least as it relates to addiction, we've become enlightened the more that we understand about that 6 inches between our ears and how our brains work and what really changes behavior and what doesn't. We're getting better at it, but I mean, there's still a lot of momentum left over from the 90s, and which was just this mindset. Well, if you break the law says this is the range of punishment. That's just what we do. And we haven't been very good at just really paying attention, like Chris is saying, engaging in evidence-based practices that address risk and need. There's a movement in the United States, at Oklahoma, at least as far as I'm aware, haven't embraced yet. It's called just data-driven prosecution. So, instead of you have a crime that says, well, your crime is punishable by 1 to 5 years in prison, and the prosecutor and the judge just guess at what the right number is. I feel like this is a 3 or this is a 5, or with data-driven prosecution, we go back to really understanding who this individual is, what's driving the behavior, what's underneath that. You pull back the addiction, and when you pull back the addiction, you're going to find the trauma, or you're going to find the untreated mental health. And there is a need for some accountability in there, and some behavior change that has to take place, that a lot of times the person with the mental illness or the addiction that doesn't really want to do. And so they're not always a population that's really that sympathetic whenever they've committed crimes, and they don't always want to change. They don't always want treatment. But the truth is they do get better. They do get better, and they can change. But we have to approach this with what I call moral humility, which is just being humble about how they got here and how we solve the problem, and really just try to focus on what's really going on here. Like I said, in the last decade, I think we're starting to understand, at least everybody here in this panel and people that are probably watching this, but we have to do a much better job at kind of educating the public at large, especially judges and prosecutors, and even defense attorneys, really.
Absolutely. Whitney, did you have something to add?
Always. I just am going to add to, for the mental health side of things, I think the state has come a really long way in the treatment aspect, but I think we have a really long way to go in the prevention side of things. And so we're seeing a critical mass issue where we are not intervening early. And so people get to a crisis point, and then the system can't handle all of the people at a crisis point. And then you see the spillover into the criminal justice side of things. I think for the war on drugs is the next thing I want to kind of segue into. Back in the 1970s, Nixon declared a war on drugs. By the 80s, Reagan and the federal administration had really invested financially in combating this war. You might remember from school days, the First Lady had the Just Say No campaign. And I think a lot of our racial inequities in the criminal justice system stem from these policy choices, because there were really large discrepancies in the mandatory minimums that we saw for different drugs. So there was there was a higher threshold for the amount of powdered cocaine than you would see for the amount necessary of crack. And 80% of crack users were African American. And so this disproportionately impacted African American men and communities of color. So I just wanted to bring that up when we're having these conversations. I think that a lot of the racism is intentional and embedded in the policies that were passed and in the criminalization of what should be considered a public health issue.
Yeah, I'm really glad you brought that up, because that was actually my next question, how like the stigma or the face we put on it, how it affects how we, address it. Well, then I'm going to move on because you already answered the question. Dr. Beeman, let's talk about the science behind the addiction, because I think if we have a greater understanding of it, maybe people will have, know a better way to address it, how to address it properly, at least. I know you have some slides you like to share.
Thank you for giving me the opportunity. I'm just going to show you guys a few slides. I put together a few here for you. Can you see that? Are you seeing the PowerPoint?
Yes.
All right, perfect. The first thing I got to tell you, and Judge Stoner said really most of what I'm going to tell you. He already stole my thunder, so it's always refreshing to see judges do that. Addiction is a brain disease. And when I have pneumonia, my symptoms are coughing, I may have a fever. And when you have addiction, your symptoms are going to be things that are behaviors. You're going to be dishonest. You may engage in criminal activity, but you're always going to prioritize the substance over other things. And so we have to understand that. And if you view it as a symptom, not as a bad person, but as a person with an illness with a symptom, right? They didn't commit a crime as much as that's a symptom. And we need to treat the underlying disease. If we want people to stop coughing with pneumonia, we give them antibiotics. If we want to stop the negative behaviors of someone with addiction, we have to treat them. And as Judge Stoner said, like, treatment works. So we definitely should not give up on that and should not feel futile when it comes to treatment, because it works. The biggest thing about this slide is this word right here, disease. It's a disease. I'm a physician. I treat patients with addiction. It's not a moral failure. I'm not a pastor. I'm not a preacher. I'm not a priest. I'm a physician. I hospitalize people for this. I bill insurance companies for this. I prescribe medications for this. This is a disease and not a moral failure. To prove that to you, here are some brain images. And the first image is a normal brain who's never used methamphetamine. This last image is someone who has been clean from methamphetamine for 2 years, someone in recovery for 2 years. And then the middle image is someone who has not used methamphetamine for a month. So consider this a long-term user, fresh into recovery. And what you're looking at are the red areas, and that's the amount of dopamine receptors you have in your brain, dopamine being the pleasure molecule. And when you use methamphetamine, you suck dopamine out of every corner of your brain. It goes up 1,400 times normal, more so than any other substance that a human being can take that I know of. Really gets so using methamphetamine is incredibly pleasurable. And you get an intense, very brief euphoria. But look at what happens after you use methamphetamine for a long time. You have the absence of pleasure, right? They have no dopamine. And they're having to use more and more methamphetamine to try and even feel normal, let alone get that intense euphoria that they had in the first place. So, and these are brain changes. We can see this. They're not making it up. They're not faking it. This isn't something you can walk off. It takes years for that function to return back to normal. So a little bit of the science. This is, I think, the best picture I could use. It's so simple and it explains everything. First of all, brain development. The brain develops from the back of your brain to the front. And when I say develop, I want you to think of like wet concrete that a big like paver would come through and pave it and make it permanent. And so this is back here is where your vision is. So there are some studies that show if you haven't seen a color by the time you're 2 years old, you won't be able to see it. you don't have the brain pathways to see that color because it's one of the first things that are developed. Well, as Judge Stoner said earlier, the last thing to develop is the prefrontal cortex. And that's your good decision maker, right? And so deep thought and abstract thinking, that's why like an 18-year-old can have complex discussions on 18th century German philosophers, but still can't not drive a car fast, right? Like they're good judgment, they're impulsive, they're disinhibited, and it's all in the prefrontal cortex. Well, when you expose your brain to an addictive substance, alcohol, or maybe even a medication like an opioid or a benzodiazepine, you create a pathway from your pleasure center, that's the nucleus accumbens, to the prefrontal cortex, okay? And it's just like muscles. The more you use it, the bigger it gets. And so if you've had a drink of alcohol, one drink, you got just a little brief little trail in the woods to your prefrontal cortex. However, if you drink alcohol every day, all day, every day, you've got a 6-lane turnpike going from your pleasure center to your prefrontal cortex. Okay, and the purpose of that is to say that was pleasurable, do it again. And so your brain says, okay, I'm getting signals to do it again, so I drink again, which means I get more pathway. And it's this circle, hamster wheel that you can't get out of. And that hamster wheel we call the reward circuit. Over time, these muscles will atrophy and get smaller, but it just takes time. You got to stop exposing the brain to the addictive substance. Over time, it'll get better. The other thing I would highlight is there are very few things I can say with 100% certainty in medicine, but I can say absolutely, without a doubt, 100%, you will never get addicted if you never expose your brain to the addictive substance. You have zero chance of being addicted to alcohol if you never drink alcohol. Even after your first drink, all bets are off, right? Because all of our brains are different and we're just playing genetic roulette. Has nothing to do with the moral fiber of a person, has everything to do with their own brain's makeup and distribution and propensity for receptors. And so we have the reward circuit for legitimate reasons, right? That it, like, if every time you ate food, if it felt like someone was punching you in the nose, you wouldn't eat food, right? That makes sense. We wouldn't do it. But it's pleasurable because we want you to eat food. And it's necessary for the species for us to eat and to have sex and to have social interaction. And drugs hijack that normal system. They just do it so much better. When I eat a piece of bacon, I get a little dopamine surge at about 200 times normal. When I have sex, it's 250 times normal. When I snort a line of cocaine, it's 350 times normal. When I use an opioid, it's 700 to 800 times normal. And then when I use methamphetamine, it's 1,400 times normal. Okay, highly, highly, highly addicting. We talked a little bit about adverse childhood experiences and the epidemiology. The numbers of adverse childhood experiences is where my research is. So this is fresh off the press. If you look at basically the top 10 counties in Oklahoma for ACEs, which ones are showing up over and over again over years, over a 10-year period, and over ACEs: neglect, physical abuse, mental illness, substance abuse. And there are 3 Oklahoma counties that stick out more than the other 74. And that's Adair County, Muskogee County, and Woodward County. And so if we really, really want to focus prevention, then and my research is in the very early stages, but right now it's reflecting that these are the counties that we need to focus on. Also, you can appreciate Southeast Oklahoma. This is where I'm from, McCurtain County, and I can absolutely guarantee you that there's a lot of childhood adversity, a lot of poor social determinants of health, and you can see that really as a trend. And then just because we're talking about overdoses, I want you all to appreciate the drug overdose epidemic that we're in. This is the United States in 2003, and I'm sorry, it hasn't been on presentation mode. There we go, you guys see that now? This is the United States in 2003. The epidemic really started in 1996, 1997. You see problems here. You see Tulsa County just barely a blip. And here's the United States in 2017. And where you see red is someone dying. It's not drug use, it's a death. Greater than 20 per 100,000, which would put it at one of the top 10 causes of death. And what if I told you the top 10 causes of death increased by this amount? That's absolutely unfathomable. Well, let's look at Oklahoma. Here we are in 2003, and here we are now. Oklahomans are dying of drug overdose, which is just the tip of the iceberg. Every time you see a drug overdose, you have to think that there's 10 people that are struggling with drug addiction and need help before they overdose. Or I could show you almost identical maps because we talked about the war on drugs. This would look identical to the war on drugs for incarceration, right? That over time, we're locking people up. Now, I think that it's a complicated issue. It's definitely there are extreme racial discrepancies between who's being incarcerated and who's using drugs. And one of the ways we know that now is because of the overdoses, right? And so if Black individuals are using most of the drugs in the country, which we would expect if they're the ones being incarcerated at that rate, then they should be the cohort that is overdosing the most. And it's not. The people who are overdosing are white men, right? White men. So either we got the incarceration wrong or something else. And it just appears that we got the incarceration wrong. And when you look at crack cocaine and where it was located in the mandatory minimums, then absolutely that makes sense. So that's all I have, but I'm happy to answer any questions you have about that material.
Yeah, two side questions from the viewing audience. One was, is this, this epidemic, is it because of the introduction of Oxy to the public, or what's driving it? And then the second question is, what are the most effective treatments that you've seen?
Yeah, great question. So the first one, I'm going to go back to what we talked a little bit about on deinstitutionalization, where we stopped the large warehousing of mentally ill patients. And I've actually worked at those hospitals. And you get to the hospital and you see football fields where buildings used to be, and recognize that tens of thousands of people were in these hospitals. And in the 1960s, we started to let them out. And not only because we couldn't sustain it, but also the 1960s saw the first antipsychotic. And we started to realize, and there were some court cases that came out that said, we're locking people up for really, like, they don't need to be locked up. Just because you hear voices doesn't mean you need to be locked up. So it was the civil rights movement tied with antipsychotic medication that allowed for the deinstitutionalization. However, we didn't fund the mental health system the way we were. And so we missed a really big opportunity to get ahead of the curve there. And then quickly followed on with not only the war on drugs. It's not like drugs had always been around and we just started incarcerating for it. Drugs became way more available in the 70s, 80s, and 90s. And I mean, I could spend hours telling you about how the United States fought communism by propping up heroin distributors in Southeast Asia and Marseille, France, and all of that. But like, drugs became more available. So incarceration happened of that. And then as they became more available, then Nixon said, let's get tough, let's create a war on drugs. And instead of saying, let's treat it, right? So that's a little bit of concept. And then in 1996, December of 95, Purdue Pharmaceuticals unleashed a medication called OxyContin. OxyContin is a long-acting opioid that bathes the brain in opioids 24 hours, or like over 12 to 24 hours. And that kind of kicked off, and it was already in the works, but that kicked off a major drug overdose epidemic because we pathologized cravings. You got a backache, get a drug, right? You got a migraine, get a drug. If you have a medical problem, it's okay to use an addictive substance. And so people had car wrecks, they had back injuries, And they started seeking out these substances, and lo and behold, they would get addicted. And so the first wave of the epidemic was absolutely Oxycontin and prescription opioids, and Oklahoma was devastated. And not because we have a lot of pill mills, but when I teach on this, I say the question isn't why are so many opioids available in Oklahoma? The question is, why do so many Oklahomans want to use opioids, right? And it's because of our adverse childhood experiences and our historical trauma with the Native American tribes, the Tulsa Race Massacre, and the Great Depression. Our brains were primed, and the pharmaceutical companies just lit the match. So then that created, and just to put that into perspective, at the height of the prescribing, Harmon County in Southwest Oklahoma was writing over 205 prescriptions for every 100 people in the county. It's unfathomable, right? And now we're doing much more, but we're still much higher than the national average on prescription opioids. Don't even get me talking about stimulants and benzodiazepines, but Oklahoma has a prescription drug problem. That is now kicked off into, not now kicked off in methamphetamine. We've always used methamphetamine, but methamphetamine is now being manufactured in large quantities in Mexico and being trafficked north, and it is devastating Oklahoma. It's a nuclear bomb in your brain, and it's way cheaper and way more available now than it's ever been before. And then on top of that, we now have the same people that are bringing methamphetamine are bringing in heroin and fentanyl. And so today is the worst day of the drug overdose epidemic. More people died today than died yesterday, and more people will die tomorrow than died today. So I need everyone to just really grasp that we haven't hit our peak yet. There is a lot of good treatment available for addiction. There's evidence-based treatment. We know that it works. And for opioid use disorder, I have to highlight the use of buprenorphine or Suboxone. You can get it from any primary care doctor. So get it with your diabetes medication, your high blood pressure medication. So it's very destigmatized. And not everybody needs to go into a residential facility. Not everyone needs to go to, Betty Ford for 90 days or whatnot. Some people just need to go to their doctor and get a medication. We have medications available for alcohol addiction. And then we have treatments for mental illness that can really help people not seek out self-medicating substances in the first place. So when I think about treatment for addiction, the one word that comes to mind is hope. I have a ton of hope. If you come to me, we'll get you better. It's going to be hard, but we can get you better.
That's fantastic explanation, everything. I question for Brenda and Judge Stoner. What are the substances that you all are seeing the most in your field? Seeing pop up the most? Oh, you're muted.
Sorry, I'm muted there. It starts with alcohol. Alcohol is a drug. So some people get confused about that, but you have white drugs, red drugs, all kinds of fermented drugs. Alcohol is still probably the number one, but not really by much. I mean, number two is going to be methamphetamine, heroin. Right on, we're seeing a huge influx of fentanyl. And I agree with Dr. Beeman. This is, I think it's going to get a lot worse before it gets better. When you start understanding the economics of the trafficking, fentanyl, so much cheaper to make than heroin. And heroin is not even that, this is fairly inexpensive to make as well. And so, but it's a lot easier to smuggle. And so I think we're going to see a lot more of that. And it's going to get worse before it gets better. But a little bit of benzos, of course, cannabis now is very, it's I would say almost half of everybody in our treatment court program start off with, polysubstance. So you got alcohol and cannabis, meth and cannabis, heroin and cannabis. And so it's just, there is a lot of data available that just the availability of a substance increases the use of it. And so we're seeing a lot of that. So does that answer your question? I mean, that's the dominant.
Yeah, no, absolutely does. Brenda, I don't know if you wanted to.
Yeah, no, it's kind of the same. For me, the most drug use I see is meth. When I did women diversion programs, it was opioids and meth. But what I see the most is meth.
Okay, thank you. I want to move on. Oh, sorry.
I was just gonna, it's just kind of piggyback on Dr. Beeman's comment. So when we think about the substance, a lot of times that's the emphasis. Well, it's the opioid or it's the alcohol or it's the meth. And if you think about it, that's not the problem. That's the solution to the problem that these people have. For some reason, the methamphetamine is a solution to their problem. The alcohol is the solution to their problem. And so you got to get behind the substance to figure out what problem is that solving for that person. And when you can start deconstructing and how to solve that problem for that person, they can start to get better.
Absolutely. Absolutely. That's address the root issue. That's what I always say, we got to address the root issue. I want to bring in another perspective that sometimes people don't like to look at, but I want to just hear from Brenda, like what she has seen in terms of the challenges for law enforcement that are, encountering people who are experiencing a mental health episode or addiction issues. Like, what are you seeing?
Yeah. So first I want to say that police officers have a very, very difficult job. One of the most difficult jobs I've ever had. And they encounter so many things. They see things, they go through things that I would consider trauma. So with that being said, they still put on their uniforms every day, especially right now when they're perceived in not the best light, and they still go out there and do what they can to serve their communities. But I feel like we can always improve. And in law enforcement, I think communication is definitely something we can improve on, especially when we're dealing with someone that's going through a mental health crisis. De-escalation techniques. There's different programs that different agencies use. I really like the crisis intervention team. And I think there was funding that just recently went through to cover more CIT training. So that is really good. And I really hope more officers take advantage of that training, because that can be so helpful when you're dealing with someone who's going through a mental health crisis or is dealing with substance abuse. And another thing is that they're starting to divert these people to detox or a mental health facility, or helping them get treatment. And I think it'll get better where we're addressing those needs rather than taking them to a jail.
Thank you. Well, what are some alternatives to incarceration, and how successful are they? Because we've talked a whole lot about the problems at hand, but what are some alternatives? Chris, I'm going to address you first, and then Judge Stoner and Brenda, if you'd like to chime in. Actually, anyone else who'd like to chime in.
Sure. Thank you, Evita. I want to underscore something that Brenda just said. I recently saw a report, a presentation that indicated that mental challenges and suicide rates are actually on the increase among law enforcement nationally as well, pretty significantly. And I think it's important as we have this conversation to not lose sight of that aspect as well, for all human beings and for all Oklahomans. And I think it's very, very important that we, as we talk about increasing access to mental health services, mental health support, and what have you, that we not forget about those men and women who are on the front lines. I would also just offer that trauma is not only real, so is secondary trauma. And vicarious trauma, and there's no way that a person's able to do the job that our law enforcement is called to do without taking on some of that secondary and vicarious trauma. And I think that that's such an important point. Brenda, thank you for making that. And then I also wanted to say, just to kind of tie in some things before we get into the meat of your question, is I think the other issue that has led to, really high incarceration rates for people who battle core issues associated with mental illness or addiction is just the stigma that has permeated these issues historically in Oklahoma. I don't want to take away from the positive movements that we've seen. I think Judge Stoner, I think Dr. Beeman are spot on. We're beginning to kind of change the way that we see and view people. Maybe we're not seeing it so much as a moral failure as we have in the past, and we're starting to see it, in a different light. And Whitney, I just want to call it out. That's because of your leadership and the work of the Mental Health Association. I think Terry White deserves a lot of credit in this regard. Carrie Slatton Hodges is doing unbelievable work to improve to eliminate the stigma, as is Director Crow, Scott Crow. I just think that there's a lot of tremendous leadership at this moment in time. Judge Stoner, you're at the front of that list. And so in that regard, there are bright spots. There are bright spots in the state of Oklahoma. I think that, the Department of Corrections administers community sentencing as an alternative to incarceration, particularly for individuals who may need access to treatment and would do just fine in the community with proper support and accountability. The Department of Mental Health and Substance Abuse has drug courts that are being used very effectively throughout the state and in many areas, mental health courts as well, veterans diversion programs, female diversion programs, and so on and so forth. And so I think it's really important that we acknowledge and give space to the bright spots that are happening. I live in Oklahoma County, or I live in Pottawatomie County, work in Oklahoma County, so I get to see my community benefit from Judge Stoner's leadership. And drug courts and mental health courts and community sentencing are fantastic. I believe in them with all my heart. And we haven't even talked about women in recovery or remerge or some of the other incredible diversion programs that exist in Oklahoma County and Tulsa County. And where these alternatives to incarceration, where these alternative courts exist and are being used effectively, it's tremendous. And man, what a godsend for the participants, for the residents who live in those areas. The reality is there are still areas in Oklahoma where alternatives to incarceration do not exist. Alternative courts aren't present, or if they're present, they're not being utilized to their full capacity. So I think it's really important to put emphasis, and Dr. Beeman said this, there are counties that we know are at higher risk. We need to really have some serious conversation about what we can do to make sure that those communities are properly resourced to have viable treatment options available, and then to also have alternative courts and funding for alternative courts that can be utilized in an effective manner. Whitney, you might want to expand on this, but one of the things that was pretty startling is that suicide and attempted suicide rates have increased pretty dramatically during the pandemic. And the increase has really been seen and experienced more in the rural parts of our state, in the rural areas. I haven't looked at the research to fully unpack that, but I suspect that a lack of access to help may be a factor in that. And so I think as we celebrate and acknowledge that we are making gains and that there are plenty of bright spots to hold on to, Dr. Beeman used the word hopeful. I think that that's the right word. I think that we hold on to that, but that we also continue to grow and continue to work to increase funding for access to mental health treatment, trauma care, and substance use disorder services throughout our state.
Yeah, and just to add some really quick context to the rural suicide rates, we've seen that increase about 27% from 2019 to 2020. And then if we just considered just rural Oklahoma and compared it to other states, we would be the third leading state for suicides. So it is very, very pervasive in our rural communities.
Wow. What are some policies or solutions you all suggest to address this, whether it's law enforcement that are encountering secondhand trauma, have their own issue, whether it's in the rural area, what are some things that we can do? And this is open to anyone and everyone.
Well, I often, people say, well, how large is your treatment court? How large should it be? And I do think we have a lot more room for people in treatment courts and diversion programs. We're like everybody else. We got a lot of restraint based on funding and budgeting, and so it's a challenge. If we wanted to grow, we got to figure out how to grow. We got to go figure out how to get a grant or expand. But really, the long-term vision isn't to have a great large program. The long-term vision is to go way upstream. If you've heard the saying, it's not, instead of pulling people out of the river, go upstream and try to figure out why they're falling in. And so, the further we can get upstream, with our build into the ground floors of our schools and, our other institutes, even, there's an initiative right now with the Arnold Foundation around, law enforcement assisted diversion. Had a lot of emphasis on training that's working in other communities. So these are people that they didn't make it to the courthouse, are diverted early on with police contact. And then there's, even go upstream before there's a problem. But it's our treatment courts, they do work. I mean, they're very effective. I'm really proud to say that, to get into a drug court, these are usually programs of, we'll say, last chance. So you did not do well on normal probation, usually multiple times, or you've already been to prison once or twice and you're back again, and you have to have a moderate to severe substance use disorder. And so if you go through a treatment court program, which these are 18 to 24-month programs, so change doesn't happen quickly, but if you skillfully engage a person and help them spark hope and help them with that traffic jam of life, I'm really proud to say we have an 83% graduation rate. And so, more than 4 to 5 people that come into these programs that were headed to prison originally, they get their lives back. We restore their lives and their dignity and their jobs, and they have hope. They have tools and coping skills and real recovery. A lot of them have real recovery. And matter of fact, we've even had recently, we just hired a program coordinator for our drug court that graduated our drug court in 2018. And so, it's there's a lot of reasons to be hopeful. There's still a lot of work to do. It's education. So much of it is just really education and trying to help people understand and pull back the layers of the trauma, unaddressed mental health issues. The genetics even play a role. Dr. Beeman touched on that. Genetics play a role. People don't choose their genetics, but if you happen to have certain genes that are hereditary, frankly, you process this, socially acceptable to have a drink. Well, guess what? Some people drink and they can't stop. It's not fair to say, well, I can stop, therefore you can stop. It's almost like saying, well, I'm not lactose intolerant. You shouldn't be lactose intolerant. I can eat peanuts. Why can't you eat peanuts? I mean, it doesn't work like that.
Yeah, I agree with Judge Stoner. Preventative would be much better. And I think we need to start from a very young age. Hopefully get some coping skills in schools, learning how to deal with things in schools, and then go from there. Community sentencing actually has a bill coming up, House Bill 3135, that wants to change the language from felony to crime. So we're hoping that we're able to help people before something becomes a felony crime. Getting people the treatment before it becomes a crime would be ideal. But at this point right now, for community sentencing, we want to keep people out of prison and in our community if they're able to. And we have the funding to do it. And we're hoping to be able to go into even the rural communities in Oklahoma. So hopefully we can help more people than we are right now.
Yeah. Awesome.
Oh, and I actually wanted to add, if you don't mind, we do have administrative orders in place in Oklahoma County, Potawatomi County, and Tulsa County. So that means if someone is on regular probation with the Department of Corrections and they have mental health needs or substance abuse needs, and they need treatment and they can't afford it or they can't get transportation where they're at now, they can talk to their probation officer and get switched over to community sentencing. And if they don't know how, their probation officer is very welcome to reach out to me. I will be happy to help. You can email me at brenda.gale@doc.ok.gov.
Yeah, that's amazing. Thanks, Brenda.
Hey, Evita, I just would want to add to this, and you guys are giving some really concrete, and I would just kind of also want to back up and take a little bit of a 30,000-foot view and talk about the need to continue to work a little bit on our culture and destigmatizing individuals who may battle mental illness or addiction. The other bright spot is we're not incarcerating individuals for these particular issues at a rate that we were, 5, 6, 7 years ago. So we're making gains. We really are, and I think it's important to not to not lose sight of that. But I do think it comes down to education, awareness, training. But then I'm also a big believer, and Judge Stoner, I'm still on your thunder here, that people tend to become what they're encouraged to be, and I think incentives and rewards for good behavior and for compliance is something that we all respond well to, including local communities and counties. And so if there were a way to as we collectively join forces to educate, to raise awareness and to really begin to advocate for a better approach for individuals who battle these core issues, I think it's really, really important that we consider advocating for additional funding so that communities can be rewarded that move in this direction. And so for those communities that are working hard to keep people from prison and, directing them and connecting them with treatment and appropriate services and supporting that individual, I think they ought to be financially rewarded. I mean, I think it's a cost saver. It's got to be a net cost saver because incarceration is very, very expensive, not only from a human capital standpoint, but also from a financial standpoint. And if there were a way to not only help these communities, and it's all of us that need a little extra support to move in this direction, to financially reward those communities so that they have access to treatment and they have access to mental health services and trauma care and things of that nature. I think that would be a very, very important element. I think it's not enough just to say, hey, do better as a community. I think it's important that we collectively work together to resource our communities. The good news is we're kind of in a unique moment with the American Rescue Plan Act monies that Oklahoma has obtained, and I'm sure hopeful that a significant portion will go to this very cause, so that we can build the infrastructure that would allow us to build on the momentum that's occurring right now.
Mm-hmm. Thank you, Chris. Gina, what do you think for solutions?
Well, I believe that we've made a lot of progress. Of course, I'm a big advocate for team. We have resources available for those coming out of incarceration. Not in the rural areas, but in the Oklahoma County area. I think we need more programs in the rural areas that, we see a lot of the recidivism coming from. I think just, it's a big hurdle to come out of incarceration when you're looking for housing, you're looking for jobs, you're looking for mental health resources, you're looking for, surrounding yourself with a group of people that want to help empower you instead of tear you down because you have the felony on your back. From my experience, and it's gotten a lot better since I came out of incarceration, and even way before, when you say the felon word just will cripple you and run you back to addiction, because you have to face that question over and over wherever you go, whether it's employment, whether it's housing, wherever you go, even to get medical, to get medical insurance. They ask you the question, have you had an addiction? And a lot of times you're turned away. And so I think we've gained a lot of ground, but we still have a lot of long ways to go. But I think we have these webinars and people that are drug courts, like Dr. Beeman, and all those that are willing to help and empower the people coming out of incarceration, and not letting them see themselves as a disgrace, but but as worthy of rebuilding their lives. And so I think we have a lot of champions out here that are willing to provide, the resources for the individuals coming out of incarceration. And I'm happy to work at Team every day to tell those women that come to our classes that you can rise above. I am a prime example of that. And so when we have a group of people like on this team that are willing to help, then I think we'll see the incarcerations go down for mental health and substance abuse if we can look at the individual as the individual coming into the court system and not as a number, that our criminal justice system wouldn't become a crippling justice system, but become an empowering justice system to give us rehabilitation for people like that. And then we'll see the numbers in prison go down, and we'll see amazing citizens rise up that have battled addiction or battled substance abuse and become upstanding citizens in the community.
Thank you, Gina. Dr. Beeman, Whitney.
Yeah, I think one thing, I got 2 points for what we can do. Number one, I love drug courts. I love mental health courts. I love initiatives. I think it's really important that anything we do is evidence-based, that it has a solid, it's not just a good idea, but that it's got evidence that it works and it's effective. And in that same vein, I think it's very important for quality control that a mental health court in Oklahoma County should look identical to a mental health court in Wagner County. And I think right now in Oklahoma, we're seeing a lot of discrepancies because of stigma. And some people may say, yeah, we'll do a mental health court, but they're not actually adhering to the policies and the statutes related to a mental health court. And I think that we need to measure that, especially in the rural areas where stigma is higher. The other thing I would say is that we definitely, I think in the public health infrastructure system, in the criminal justice system, I think we should be measuring everything. I think data will tell us how we're doing and where we need to go. And I think that's real solutions that Oklahoma can make very quickly is let's just measure. And we've got several really high caliber academic institutions in the state, including OSU. And we've got brilliant people around the state that can help us dig our way out of this hole. We have to give them the tools and the information to do so. And right now there's a lot of people that don't want to share data, or we're not collecting the data. And that's fine. We have to just recognize that, start collecting the data. And I think we would gain a lot of insight. But for me, wanting to solve addiction in Oklahoma, like I don't even know where to go. And it takes me 5 years just to find out through all these different data sources, like finally where the problem is. So it shouldn't be that hard.
Thank you.
I have something, I have an offer now. If DOC, if you guys have any parole violators that you want to send back to prison, but the parole violations related to substance abuse or some kind of addiction issue, we'd love to take them over in drug court. So I've had a couple in the past, but it seemed like maybe we're missing. So Brenda, I don't know if you have a channel. We'd love to take more.
I didn't know that drug court took parolees, but I think
the statute allows it. It's
Yeah.
rare for us to get one, but we've been trying to create a pipeline or a channel to get more. And so if since you're here, I just thought I'd mention it because we'd love to have the statute would permit that. And so
I think that's awesome. Yeah. I will shoot you an email. I think that's great.
okay.
Awesome, collaborating for people. Whitney, go ahead.
So I want to throw out housing as a potential policy solution. Evita knows, at least in my previous life, I was an educator, 6th grade English language arts. And so there was a common phrase that we would use a lot. You have to Maslow's before you can bloom. And how this translates to this context is it is very difficult for people with substance use disorders or mental illness to really engage with treatment if their very basic human needs aren't being met first. So water, food, shelter. Mental Health Association Oklahoma does a lot of work with permanent supportive housing, and we've had great results in keeping people with mental illness housed, compliant with treatment, out of incarceration in the court systems. So we really need to focus on permanent supportive housing. And then just in general, Gina said it beautifully, like there is active harm being done. Not only is it just neutral, it's active harm for people who are exiting incarceration. It's much more difficult to find housing, especially in our housing market right now. There's a lack of affordable housing, and we're in the midst of an eviction crisis. So as much as we can incentivize the building and maintenance of affordable housing, that will translate to more options for people who have a criminal record. And then to kind of leave it on a hopeful note, I do want to mention an exciting upcoming change that is happening, and that is 988. So 988 is going to replace the very long national suicide prevention hotline, and they're going to make it very similar to 911, so it's easy for people to remember. This was passed by the federal government and will go into effect in all 50 states starting July 1 of this year. Why I think it's relevant for this group is because this will decrease the amount of interaction between those with mental illness and law enforcement responses. People with untreated mental illness are 16 times more likely to die at the hands of police. We appreciate the work our law enforcement officers do, absolutely, but I think many of them would tell you they don't have the training to handle a lot of these cases. So I think that what 988 is going to do, if someone needs further help than what is available on the hotline, this dispatch system will actually be able to deploy mobile crisis units with behavioral health professionals who can either help the family create a safety plan, they can do referral services and make sure that person gets follow-up care, or if necessary and they need a higher level of care, that mobile crisis unit can actually transport them to a facility with a bed. So I think that is going to be huge and a very big shift that we'll see for how this looks in Oklahoma and across the country.
Yeah, no, that's wonderful. Yeah, if you have the information, we can get the information to people when it comes out. Judge Stoner, so this is a question that's come up, I've heard pop up several times. Is there a general understanding among judges about like what to do, or how to direct someone that appears before them that may be suffering from addiction or mental illness? Is there like a standardized or mandatory training that judges have to go through?
Unfortunately, no. That's kind of been an initiative of mine, sort of a pet project, in the way that, I mean, even up to a couple of years ago, there wasn't even a single continuing education class on addiction for judges. And so, unless you were in a treatment court, I mean, if you're a specialized judge, that's one thing, but if you're a family law judge or a criminal judge, there's not a lot of specialized training around addiction. We recorded the first one through the Bar Association, so now it can be watched as a video. And so we're making it more accessible, but it's not standardized and it's not required. But that's something that we have to do a better job of, is getting our judges educated, understanding, and what's underlying here, and realize there really is solutions. People can change. You see a lot of judges are sometimes kind of jaded because of what they're seeing. But when they realize that your past doesn't have to equal your future, but like if you're really not engaged in a serious evidence-based, data-driven decision-making and process, you can get lost and caught up in emotional decision-making, because it's a frustrating population to work with. I mean, it can be, and you got to have a lot of patience. And like I said, recovery is often a process of 2 steps forward, 1 back. And one of the big problems we have is giving up too soon. We give up way too soon. We're going to be working on that.
Okay, thank you for that. And Dr. Beeman, are there any innovations that you all are working towards in this area? Oh, you're muted.
Sure. OSU, has been very, very active over the last 5 years, really led by President Schramm. in the field of addiction. President Trump has actually been to Hazelden Betty Ford herself, and it's just absolutely unheard of for a Division I president to be that involved in trying to understand the system. So we're very, very fortunate for her leadership. And we've just, really exploded at OSU. There's so much to talk about. We were the recipients of the Purdue settlement for $200 million. We have, first off, with that money, our number one priority was to provide addiction treatment, evidence-based academic excellence addiction treatment to any Oklahoman without the ability to pay or without the ability to drive. So we have partnered with our community mental health centers and our FQHCs. So now that anyone anywhere in the state can get access to the OSU Addiction Medicine Clinic, and we don't care how you pay, we're not going to charge you, and you don't have to drive. So access has just exploded. We are doing a lot of research. We have a multi-million-dollar brain imaging center. We now have one of the top MRIs in the country, mostly because, these things update every 5 seconds. So like right now, we're the belle of the ball, but 2 weeks from now, it'll be out of date. But Oklahoma is actually on the map for brain imaging of addiction. I could go on and on and on, but this is definitely the Renaissance era for OSU and for Oklahoma in addiction treatment and discovery.
Well, that's promising from what Judge Stoner is working on and what you all are working on and what's coming down the pipeline from Mental Health Association, and everyone is a promising future, at least. I do want to go back to something that Chris mentioned. Chris, you talked about cost. So let's talk about the money. Okay. So Chris or Whitney, what is the cost comparison to incarcerate versus, treat in a diversion program or alternative program? Whitney, I'll put it to you.
It is a really big difference. Drug courts are typically about $5,000 per person, whereas incarcerating someone is about $19,000. And if you factor in that someone you're incarcerating has a serious mental illness, it's more like $23,000. So not only does something like a drug court or mental health court allow people to maintain ties with their community and get the actual treatment they need, it is far more cost effective, and it just yields better results. There's lower recidivism rates, there's higher employment rates, there are, they're just major benefits. Then I also pulled 2 other data points. A single hospital stay can cost $15,000. And then for a child entering foster care, that is around $21,000 per year. So yes, there are direct costs that we can attribute to the person who is receiving treatment or being incarcerated, but there are also some other costs that we could factor in. And so, yeah, it is the most humane option to provide people with alternatives to incarceration, but it's also the fiscally responsible and effective option as well.
Thank you.
And could I bring up a data point to piggyback on that? We did a study at TCBH, which is the local crisis hospital in Tulsa. In 1 month, which was our study period, 56% of admissions were related to methamphetamine. So that's like over half of our mental health beds are because of the substance. And if we really want to save dollars and save those beds, which are really hard to get into now, we have to, again, address that addiction issue. There's also something else I want to clear up. Dr. Shrum went to Betty Ford to try and get them to come to Oklahoma and partner with us. She did not go as a patient. I want to be clear.
Thank you for the clarification.
Hey, but we're destigmatizing, so if she did, it's okay.
That's right. Nothing wrong with it.
Absolutely.
Exactly right.
Go ahead, Chris.
A couple of things I want to add. This conversation is so deep and meaningful and significant and smart and unbelievable. I mean, my goodness. We're talking about going upstream, Judge Stoner. You talked about, we're talking about prevention, and wouldn't it be great, because we're talking about, avoiding and diverting people away from prison, but we are also holding people who are suffering from mental illness and substance use disorders in our jails prior to conviction. There's a statistic that was very sobering that we stumbled upon last week or the week before last, that Oklahoma actually has the second highest jail morbidity rate per capita in the nation, and that 95% of everyone who dies in an Oklahoma jail dies prior to their trial, or prior to a resolution on their sentence. They die innocent. You're innocent until proven guilty. And so as we have this conversation and talk about moving upstream, as we begin to resource communities to create greater access, it would be greater, and invest in, Brenda, you said this, but invest in crisis intervention training for law enforcement, and so that people are diverted from involvement in the criminal legal system entirely. I mean, that I think is the goal. One way that we can get there, one tangible way that we can get there, or at least take steps toward that, is by funding State Question 781. So the reality is, when the voters decided that they did not want to continue to send people to prison for simple drug possession or low-level property crimes, and reduce our prison populations for those offenses, the second part of that was State Question 781, that directed the savings from avoiding those prison stays to be redirected to local counties to invest in mental health services, trauma care, and substance abuse treatment access, greater access as well. That funding has not materialized yet, and I get, listen, we need to protect funding for the Department of Corrections. I'm all for that, but at the same time, there's no reason at this moment in time that we cannot begin to invest and redirect savings to local counties to beef up access and their infrastructure around mental health and substance abuse services. That can be done through State Question 781. It's the prerogative, it's the responsibility of the legislature to make sure that that funding materializes. But the other component of that, and I think this is so important, is that State Question 781 gives local communities buy-in. So local communities working with the Department of Mental Health and Substance Abuse would determine what their greatest needs are, so that they can have some say-so in how that savings, when it comes back down to the local level, would be utilized. And I think it's very, very important to really advocate for that funding to be redistributed to local communities so that we can build the infrastructure and create greater access to mental health, substance abuse services, and trauma care.
Thank you, Chris. Well, we have about 4 minutes left. So I want to give last thoughts for everyone. What do you want to leave with our audience, or maybe someone who's still on the fence and thinking that, we just need to incarcerate people, that are experiencing these health crises? What would you say?
You better build a lot more prisons.
I would say that incarcerating people with substance use disorders and mental illness is just perpetuating the cycle. We're going to get more of the same unless we change how we do things. And we should be treating our neighbors like people with health conditions, not like criminals.
I believe, I want people to know that people can change. Your past does not have to equal your future. You've had tons of trauma. You've had tons of horrible life experiences, no job training, whatever it is. Your past doesn't have to equal your future. But we have to give people the right tools, support, encouragement. And as leaders, we're the ones that are responsible for creating the framework in which people can be successful. And so right now, our framework in terms of what people can, the system that they're in, is just got to get better and stronger. So to embrace what we call risk need responsivity, which is, what is the real issue? Everybody, if you think about addiction, is like being in 4-lane traffic jam of 20 cars, and the drug is just a car that's in front of you. Well, that car can't move until the car in front of that can move, and that can't move until the car in front of that can move. And it's a traffic jam, and it's access to housing. It's access to meaning, it's to treatment. It's job stability, housing. And so addiction is a systems issue, and it's a system solution. And it's not rocket science, it's just hard work. And we have to have the patience. And if you want to solve a problem, you got to get close to it. And you got to be patient and spend your time trying to unclog that traffic jam for that person.
Thank you. Gina, Chris, last words.
I just want to say, I like what Dr. Beeman says, is to show there's hope. I'm a big advocate of that, coming from where I came from and the issues that I face. Losing a daughter to suicide for mental health issues, just giving them hope. And I know that coming through team, we pump a lot of hope into the ladies that are incarcerated, that's coming out of incarceration or walking in every one of our programs. So we could get more people besides our faith-based programs to give people hope once they come out of incarceration and dealing with substance abuse or mental health, then we'll see a change and a rise in success stories.
Thank you, Gina.
I do want to say real quick, I know Chris was saying some nice things about me earlier, but I remember 8 years ago, man, I was the one saying that this is a really, really messed up system. I've been a prosecutor and defense attorney, and I was rather hopeless until Chris came out, and he was one of the very first people with power and authority. And so this is something we can change. It frankly gave me the confidence to think this can be different. And gave me the confidence to kind of stick my neck out there and say, okay, let's do this. And so thank you, Chris. I don't know if I ever told you that, but.
Well, my goodness, thank you so much for everything that you're doing. You are, somebody said it in the chat, you are the standard, Judge Stoner, and I thank you for that. And thank you for those kind words. Evita, my thought is this, and I say it often, there is no such thing as a spare Oklahoman, and we cannot afford to give up on one another.
That's really great. Everyone, everything that you all said, I want to thank each and every one of you for being here and for the work that you're doing in our community to help us get better and give us a brighter future. And just, you all are amazing leaders. This concludes our panel. Again, thank you for giving up your time, and thank you everyone that's tuning in. If you'd like to learn more about this issue and policies, effective policies to address it, you can check out all the websites of the organizations that are represented here. As well, you can visit our website, and we have some articles there and data available. But please do go and educate yourself, spread the word, keep the conversation going, and yeah, be the solution. Take care and have a good night.
Thanks,
Thank
everyone.
you.
Bye, everyone.
Bye. Thank you all. Thanks, Judge Stoner. Bye, Gina.
Thank you.